Performing any kind of medically required procedure on an infant requires critical evaluation of the baby's clinical status and weight or size. In the lumbar puncture procedure, this is especially important as it relates to the development of the infant's spinal cord. When performing this procedure, it is critical to know your landmarks and not to deviate from them, to not compromise the clinical status of the baby, and additionally, to use absolute sterile technique. In this video, we will look at some common reasons for the lumbar puncture procedure, contraindications, and possible complications, and will demonstrate how to prepare for and perform a successful procedure on a term and a premature infant. A lumbar puncture procedure is performed whenever a sample of cerebral spinal fluid, or CSF, is required for diagnostic evaluation. The most common reasons for the procedure are for evaluation of meningitis, metabolic problems, or intracranial bleeding. It's also an important therapeutic tool for the treatment of communicating hydrocephalus associated with intraventricular hemorrhage, to inject chemotherapeutic agents, and to instill contrast material for myelography. It's inadvisable to perform the lumbar puncture procedure on infants who have bleeding diathesis, local infections at or near the puncture site, lumbosacral anomalies, increased intracranial pressure, and unstable cardiorespiratory status that may be further compromised during the procedure. In the lumbar puncture procedure, complications are rare but include hemorrhage into the epidural, dural, or subarachnoid space, trauma to underlying tissues, herniation of a nerve root, late development of spinal epidermoid tumors, and infection. Complications can be minimized if the following 5 steps are taken each time a procedure is performed. Use a spinal needle with a stylet. Use meticulous sterile technique. Always position and restrain the infant properly. Limit the number of sticks to the infant. The best rule of thumb is no more than 2 to 3 sticks. If after 2 or 3 sticks, clear CSF is not obtained, then someone else should attempt to make the puncture. Limit the number of lumbar puncture procedures. The lumbar puncture procedure requires 2 highly skilled people, the practitioner and the assistant. To prepare for the procedure, the practitioner needs to obtain sterile gloves, betadine, patient labels for the CSF specimens, and a prepackaged lumbar puncture kit. These kits generally include sterile drapes, 3 numbered tubes for collecting CSF, a tray with a well for betadine, 3 scrub brushes for prepping the puncture site, sterile 2x2 pads, 1% lidocaine solution for injection as a local anesthetic agent if used, and a 22-gauge spinal needle, preferably with a clear hub, which allows for immediate visualization of CSF flow. Working very closely with the practitioner, the assistant must focus on 3 tasks: monitoring the infant so as not to compromise the patient during the procedure, immobilizing the infant to minimize trauma from any movement, and positioning the infant to provide maximal exposure of the intervertebral space. Depending upon the infant's needs, the monitoring equipment will vary, but usually includes a continuous heart rate and respiratory monitor, an oxygen saturation monitor, a transcutaneous carbon dioxide or oxygen monitor, an overhead table or an isolette with servo-controlled heat source, and warning lights for larger babies in open cribs or for smaller infants who are taken out of their isolette for the procedure. After attaching the necessary monitoring devices, the next step is to position the infant. There are 2 positions used for the lumbar puncture procedure: the lateral decubitus position and the sitting position. In the lateral decubitus position, it is important to identify the practitioner's dominant hand, left or right, and to position the neonate's head on the opposite side of the practitioner's dominant hand. Looking at this more closely, if the practitioner is right-handed, as demonstrated, position the baby's head to the left. Since the needle must be inserted so that the tip of the needle is directed toward the infant's head, this allows easy access to the intervertebral space. The baby is now turned with his head to the right side to demonstrate the difficulty of performing the procedure for this right-handed practitioner. This position requires that the practitioner hyperextend her wrist to correctly insert the needle. The angle of this position is hard to control and difficult to maintain. The sitting position is also used. It may be preferable to the lateral decubitus position if there is difficulty in obtaining CSF. This position is more difficult to maintain, particularly in larger and more active neonates. Care must be taken to ensure that the airway remains patent or open. In this first demonstration, we will use the lateral decubitus position and a full-term neonate. This neonate required a lumbar puncture to evaluate for possible meningitis. For the lateral decubitus position, the assistant places the infant on his side, flexes the knees to the chest, and bends the head, being careful not to occlude the airway. The lower spine must be adequately flexed to provide maximal separation of the vertebral bodies. The neonate should be held in a flexed position with the spine parallel to the table. At this point, the infant should not be rotated, as this will affect the position of the vertebral bodies and interfere with access to the subarachnoid space. Looking at the vertebral column, we see that it is composed of 7 cervical, 12 thoracic, 5 lumbar, and 5 sacral vertebrae, as well as the coccyx. The area involved in the lumbar puncture procedure is the lower lumbar region, and this is where it's critical to look at the skeletal development of the infant. To illustrate this more clearly, let's begin with an adult spinal cord. In the adult, the tip of the spinal cord is at the top of the second lumbar vertebra. In the full-term newborn, the regression of the spinal cord is not yet complete, and the tip is usually between the second and third lumbar vertebrae. And in a 24-week premature infant, we can see that the spinal cord terminates even lower. To prevent trauma to the spinal cord, it's necessary to identify where the spinal cord ends and then to sample fluid from the subarachnoid space below the end of the spinal cord. The lumbar puncture procedure will first be demonstrated on a full-term neonate, followed by a preterm neonate. Because the infant has to be restrained during the procedure, it's very important to complete as many preparations as possible before beginning the procedure. As the infant is being positioned, the practitioner or the assistant opens the sterile prepackaged spinal tray, pours betadine into the well, puts on sterile gloves, and arranges the equipment on the tray. The spinal needle is inspected for ease of withdrawing the stylet. The tops are unscrewed from the CSF tubes, and the tubes are placed upright in their holders. The practitioner then steps into position at the patient's side. Next, the practitioner preps the area over the puncture site with a standard sterile scrub, moving from the anticipated puncture site in a circular motion out to the periphery. The area is scrubbed 3 times with betadine and allowed to dry. The iliac crest area should also be prepped if a second drape is not used, as will be demonstrated here. 1 sterile drape is placed underneath the neonate. Know the anatomic landmarks and don't deviate from them. The practitioner palpates or feels for anatomic landmarks with the non-dominant hand. The landmarks are the iliac crest and the spine. The index finger is placed over the iliac crest, and the thumb is placed on the spine. An imaginary perpendicular line is drawn straight down from the iliac crest to the spine, and the vertebral interspace is felt at that point with the thumb of the same hand. This space corresponds to the L3-L4 vertebral interspace level. The practitioner will then move 1 space down to the L4-L5 interspace for the first puncture. The practitioner picks up the spinal needle, and while still holding the insertion site with 1 finger, inserts the spinal needle into the interspace. The needle is aimed slightly cephalad or towards the umbilicus, with the bevel of the needle directed toward the head. The needle should be advanced 0.5 to 1.5 centimeters, depending on the size of the baby, until CSF is obtained. You will note that the activity of this full-term neonate is causing a fair amount of movement in the spinal needle. It is important that the assistant continues to restrain the infant in the correct position to minimize trauma that may be caused by movement of the needle. In addition, a blood vessel may be nicked, which could cause contamination of the CSF with blood, interfering with interpretation of the CSF results. The correct position for needle insertion is directly between the vertebrae. If resistance is met, withdraw the needle slightly and redirect it or reposition the infant. The practitioner has most likely directed the spinal needle either too far cephalad or too far caudally, so that the needle is coming in contact with the vertebra. This may also result if the infant is not restrained properly, causing rotation of the spine. This is a frequent problem with large neonates. Once the practitioner inserts the needle and does not meet resistance, the stylet may be removed to check for CSF flow. However, in many cases, the CSF will flow around the stylet while it is still in place and is easily visualized if the needle has a clear hub. In our experience, a pop is rarely felt when the ligamentum flavum and the dura are penetrated in the newborn, as is the case with older children. If no fluid is obtained, or if the fluid is bloody, the practitioner may attempt the puncture one space above, at the level of the iliac crests, or one space below the initial puncture. If unsuccessful on the first 2 or 3 attempts, someone else should make the puncture. If bloody fluid is obtained, the practitioner needs to determine if a vessel was hit or whether the fluid is truly bloody CSF. A traumatic tap or a tap where a blood vessel is hit is evidenced by bloody CSF that clears in the 2nd and 3rd tube, previously clear CSF that then turns bloody, or non-clearing bloody CSF that forms clots. Truly bloody CSF as a result of blood being present in the subarachnoid space prior to the procedure is suggested by bloody CSF that does not clear or clot. Once CSF is obtained, the practitioner removes the stylet completely, positions the first CSF tube under the hub of the needle, and collects 1 cc of fluid in each tube. Typically, the first tube is sent for culture and gram stain, the 2nd tube for glucose and protein, and the 3rd tube for cell count. However, the tube with the least amount of blood contamination, the clearest fluid, should be sent for cell count. Additional fluid may be collected depending on the studies requested. Once the appropriate amount of CSF is obtained, the stylet should be reinserted and the needle removed. A sterile 2x2 pad is placed over the puncture site and pressure is applied. A small bandage is applied over the puncture site and the excess betadine is washed off. We will now demonstrate the LP procedure on a premature neonate. This neonate is a 650-gram, 9-day-old who required a lumbar puncture to rule out meningitis. This neonate is intubated and on a respirator on low support. In performing the procedure, it is critical that the practitioner assess the neonate's ability to tolerate the procedure, particularly the respiratory and cardiovascular systems. The neonate is monitored with heart rate, respiratory rate, central blood pressure, and oxygen saturation monitors. Once the clinical status of the neonate is assessed and monitors are in place, the assistant prepares the equipment. The assistant places the sterile spinal needle onto the tray and pours betadine solution into the well. He then returns to the bedside to position the patient in the lateral decubitus position. The practitioner, wearing sterile gloves, sets up the 3 tubes, checks the spinal needle for ease of withdrawal of the stylet, and positions herself at the bedside. The practitioner preps the back using the standard betadine scrub, places 1 sterile drape underneath the neonate, and then palpates for landmarks. Note the position of the spine and iliac crest. The spine is much more protuberant in the small neonate compared to the full-term neonate. A second fenestrated drape is used in this demonstration and is placed over the neonate's back. The practitioner palpates again for landmarks and localizes the puncture site. This position is held with the left thumb, while the practitioner picks up the spinal needle with the right hand. The spinal needle is inserted approximately 3/4 centimeter and blood-tinged fluid is immediately obtained. This neonate has a grade 3 intraventricular hemorrhage, which is evident by the free-flowing, uniform, light pink fluid which did not clear through 3 tubes. Note how still this neonate is with very little movement in the spinal needle as compared to the full-term neonate demonstrated earlier. Once an adequate amount of CSF is obtained, the stylet is reinserted into the needle. The needle is withdrawn and pressure is applied to the puncture site using a sterile gauze pad. The sterile drape is then removed, the back is washed, and a bandage is applied. Performing a successful lumbar puncture procedure is ensured if the practitioner and assistant follow the guidelines we have seen, accurately evaluating and continuously monitoring the infant's clinical status, consistently using a strict sterile technique, knowing the landmarks to determine the best puncture site, and limiting the number of punctures and sticks for each patient.